Assalamu alaikum everyone. My name is Dr. Asaad. A few words about myself. I recently joined Shifa International Hospital in September 2019. I have done my basic cardiology training from Ireland, and then I moved to US. I did my fellowship in advanced cardiac imaging from Mass General Hospital, which is the primary teaching hospital of Harvard Medical School in Boston. And then I followed it up with fellowship in interventional cardiology from Mount Sinai Hospital in New York. And then fellowship in structural heart disease interventions again from Mount Sinai Hospital in New York. I was hired as faculty interventional cardiologist at Mount Sinai following my fellowships, where I worked for a few years before returning to Pakistan. I still hold my affiliation with Mount Sinai as adjunct assistant professor of medicine, and currently I'm a consultant interventional cardiologist at Shifa International Hospital in Islamabad. So the topic of today's discussion is recent advances in cardiovascular disease management with the help of coronary or peripheral structure interventions. So preview, we're going to quickly go through these. I know we have a very diverse audience, so we're not going to spend too much time on any particular topic, but what I'm going to do and what my all my efforts have been in while making this presentation have been towards the fact that we give a brief overview of what's going on in all these various aspects of interventional cardiology. So starting with calcified coronary lesions. Calcium, we know, and if there are any interventional cardiologists in the audience, they know has been probably our worst enemy since the time of inception of interventional cardiology. We know that if there is significant amount of calcium in a coronary artery, it's not amenable to stenting via regular stenting methods, which include balloons and stuff only. So firstly, we have developed ways of recognizing this issue before actually deploying the stent. Previously, we just go by angiography. Now we have IVUS and OCT guidance, which are all available here at Shifa. So how do we treat these calcified lesions? If there is only mild to moderate calcium, we go with non-compliant balloons, which are stiff balloons and which hold pretty high atmospheric pressure to break this calcium. And then when we move towards moderate to severe calcium, we have these cutting balloons and then angiosculpts and then rotational atherectomy, which we commonly use in Shifa as well. And then other modalities which are being used worldwide are orbital atherectomy, laser, and shockwave therapy. So cutting balloons we have discussed. Shockwave is like ultrasound waves which we use for lithotripsy of nephrolithiasis. So just quickly, I'm going to show you a case of coronary calcification, which we dealt with. It was a 57-year-old man, diabetes, CKD. This is his LV gram, which you can see pretty good LV. On echo, it was around 45%. This is the right coronary artery, which is calcified and has significant disease from proximal part to the mid. This is the left coronary system, which has significant disease in the LAD, which you can see here, and then left circumflex ostium, which is very calcified and narrowed. So we fixed the right coronary artery first with 2 stents, and then for the left, we brought him back. This is a very narrowed left main stem, which is probably the most dangerous coronary intervention that we would do. So obviously, if you have support of impeller devices, which are left ventricular assist devices, we use them for such high-risk coronary interventions. This is a rotablation device, which is like a drill machine which goes forward. And rotablation, we use IVUS, which is our intravascular ultrasound, to measure the inner diameters of the coronaries. And this helps not only in recognizing what is the status of the calcium that was there. Is it broken enough, or is it amenable enough to angioplasty, or does it need any more modification with the help of cutting balloons and stuff? And in addition to that, it also helps us size the actual size of the vessel for stenting. So anyway, we were able to size this is us ballooning with high pressure balloons, the same calcium. And then we stented this with the technique which we call as mini crush technique, where 2 stents are deployed at the same time. We would cross balloons back into them and then size the balloons according to what the size of the vessel is. Again, a well-apposed stent means a stent which is sized adequately to the vessel size, and also it is opposed to all the vessel walls. And what it means is that there is less area for the blood to go around the stent, which means the chances of stent thrombosis are minimal, and that we know from all the long-term studies. So this is us fixing it, and then we finally do the IVUS, and this is an excellent result. Coming to aortic valve interventions, aortic stenosis, I'm sure most of you know, in the audience you have seen or a patient or two or more, depending on your area of expertise of these patients who have aortic stenosis. For TAVR purposes or for transcatheter aortic valve replacement purposes, what we call severe aortic stenosis or an aortic stenosis patient who is symptomatic with severe AS must fulfill at least two of these criteria. So aortic valve area should be less than 1, a mean gradient should be more than 40, and a peak velocity should be more than 4 meters per second. Various etiologies in Pakistan we have, and I'm sure if you are dealing with the diaspora of Pakistanis and Indian nationals in UAE, you will have a lot of bicuspid disease, whereas in the West, calcification is probably the most common cause of aortic stenosis. This is a graph from Eugene Braunwald's paper which was published in Circulation in 1968. And the reason I'm showing this is that it holds true to this date. What it's showing is that until the patients with aortic stenosis are asymptomatic, their life expectancy is the same as people who do not have aortic stenosis. So even if you have severe aortic stenosis, but you are asymptomatic, you are not looking at anything hazardous. However, as soon as the symptoms start, the life expectancy goes down remarkably. And depending on what symptom you present with, if angina is your presenting symptom, half of the people will die within 5 years. Whereas if the patient comes into you with heart failure, 50% of them won't be alive in 1 year. So again, we need to be aware the symptoms and what sort of symptoms the patient is experiencing. And then at that point, we should be offering them the most appropriate therapy in terms of either surgical or transcatheter valve options, depending on the age and other comorbids. Again, we've discussed it. So there are 3 options that we have for severe aortic stenosis. The traditional option for symptomatic severe aortic stenosis is SAVR, which is surgical aortic valve replacement. What we have started doing in the last 10 to 12 years, and more commonly in the last 5 to 8 years, is TAVR, which is transcatheter aortic valve replacement. And then in palliative cases, we have the option of balloon aortic valvuloplasty, which is a temporary solution for somebody who is going into heart failure and cannot afford or is not a suitable candidate for either TAVR or SAVR. We can still provide them some sort of relief by opening up the aortic valve with a balloon. So the first transcatheter aortic valve was made in 1989 by Anderson in Russia, and it was a one-size valve done in pigs. At pretty much at the same time, Alain Cribier in France was doing the same, and they made these models of aortic valve. And what they thought at that point was that when the calcium on the aortic valve has gone beyond a certain frame or certain amount, then that calcium itself can hold a valve in its position. We don't need sutures or the surgical sutures that we traditionally have been using in surgical aortic valve replacement. So the first valve was only a 23 millimeter size valve that was one size fit all, and that was deployed with a balloon. And this is how it was deployed. This gentleman was the first person who had a TAVR done in the world, and 15 minutes post the valve, he was awake, and he was a pretty high risk patient. So we have moved obviously a long way from that point. Right now, what we deal with is a continuum of risk factors. So initially, TAVR was only considered suitable for patients who are deemed high risk or extreme risk for surgical aortic valve replacement. And then we have been moving towards the intermediate risk and low risk patients. So STS score is essentially an online risk calculator for surgeons. This is the Society of Thoracic Surgery score. It has various, you need to fill in a few points for the score to give you an accurate assessment. Obviously, it does not negate the importance of eyeballing the patient, but still it gives you a fair idea. And depending on patient's age, sex, EF, and various other valvular issues, also how recently has the patient been admitted in the hospital with heart failure, it gives you a score estimate. If the score is less than 3%, that means there's 3% or less risk of mortality within the first 30 days if the patient was to undergo a surgical aortic valve replacement. And patients with the score less than 3 are considered low risk, while patients more than 15 are extreme risk. So TAVR was initially started and allowed only in extreme risk groups or inoperable groups where the morbidity or mortality was around 15 to 50%. 2 trials were done, PARTNER 1B and then CoreValve. PARTNER 1B was with SAPIEN and CoreValve was with expandable Medtronic valve, self-expanding. So these are the results of the PARTNER trial, which showed 20% mortality, reduction in mortality when the patient underwent transcatheter aortic valve replacement versus standard therapy, which is obviously only medical therapy in these patients, because these are patients who are at an inoperable risk. Next was the CoreValve trial, again, which showed significant reduction in mortality in patients who underwent TAVR versus who underwent just medical therapy. Then we come to patients with a high risk of mortality if they were to undergo surgical valve replacement, which means an STS score of about 10 to 15%. Again, 2 trials were completed, PARTNER 1A and the pivotal CoreValve trial. And what they showed was that in the PARTNER trial, the results were very comparable to surgical valve, while in the CoreValve, there was a significant reduction in mortality, where also it was deemed superior to the surgical valve replacement if you were to do these valves with Medtronic's CoreValve rather than undergoing an open heart surgery, or what we call a surgical valve replacement. Coming to intermediate risk scores, where STS mortality is in the range of 3 to 4% to 8%. Again, 2 trials were completed, PARTNER 2A and CERTAVI trial. So PARTNER 2A trial showed again reduction in mortality after TAVR versus surgical valve replacement, and the CoreValve trial showed the same. Especially stroke was amazing, because in the high risk cohort, SAPIEN valve replacement showed that there was a signal that TAVR might be associated with a slightly higher risk of stroke. However, that data has not been seen again in any of the other valve trials other than that one particular trial. In the low risk group, where STS mortality is less than 3%, is probably the most recent group which has been allowed TAVR in US as well. First trial which was done on these patients was out of US trial, which was called the NOTION trial. And then there were 2 trials done in US, which came out in 2020, PARTNER 3 and Evolute CoreValve. So what NOTION trial showed us, which was mainly a European trial, that all complications were lower. However, the risk of permanent pacemaker was slightly higher, significantly higher in the TAVR group in the European study. In PARTNER 3, which is a US-based study, we see superiority of TAVR over surgical valve replacement in the low-risk cohort as well. And the same was seen in the Evolute low-risk trial, which showed that it was as safe as a surgical valve in these patients who are at low risk of valve replacement complications from surgical valve. So we know now that we have the entire cohort of patients with aortic stenosis covered with fairly solid data to support a use of transcatheter aortic valve replacement in these patients rather than going for the traditional surgical valve replacement. Once you have referred the patient to us, what do? We obviously have to assess them. We have to make sure that which class they fall into. Initial assessment obviously means we will do an echo and stuff. Functional assessment means we will see how the patient actually looks like and stuff. That will determine the overall procedural risk. And once we determine that they are appropriate for TAVR, then they undergo these 2 imaging modalities, to assess appropriateness and also to see if they can even have TAVR or not. So first we have to do echo where we see LV function and a gradient and stuff, and then a TAVR CT, which involves CT of the annulus as well as the entire aorta down to the femorals to see if the femorals are big enough or the iliacs are big enough for us to bring that valve up to the aorta. And then the aortic annulus actually determines what size valve and what type of valve would be appropriate for these patients. Again, various considerations. We don't need to sort of go through that. There are 3 devices which were FDA approved: the Sapien, the Medtronic, and the Accord Neo. Various approaches have come about. The traditional and the one single approach which has shown superiority of TAVR over surgical valve replacement is percutaneous transfemoral approach. None of the other approaches have really been tested against surgical valve in a randomized manner. So if a patient, 90% of our patients can now undergo transcatheter valve replacement via the femoral approach. So in majority of these patients, we get a clear benefit. Whereas the patients who are not suitable for femoral access, we need to choose one of the other accesses, which obviously means that we are reducing the benefit given to them by a percutaneous approach. This is how a Sapien valve is deployed. This is the valve at the aortic annulus. We pace the heart around 180, and then we expand the valve in the annulus. This is a core valve. We do again an aortogram to assess where the annulus is. This is a pretty old picture of the core valve, but this is one picture we can show the entire procedure pretty quickly. So this is a self-expanding valve, which is a core valve, and it gives you a lot more control, and it's retractable a few times as well if we are not happy with our positioning. And it does not, if you can notice, it does not require pacing at that sort of a speed which we needed for the balloon expandable valve. So again, patients who have reduced ejection fraction and stuff, who might not be very suitable for rapid pacing, we preferentially choose core valve in those cases. Again, what are the newer indications of TAVR? We have been doing valve-in-valve for bioprosthetic aortic valve failure. We did our first valve-in-valve case at Shifa last year, where a patient who had undergone surgical aortic valve replacement twice and had a very horizontal aorta and was extreme risk for third surgery was referred to us, and he's doing alhamdulillah very well. And then we can do it for AI as well, but we do need some degree of aortic calcium in those cases. For valve-in-valve cases, we need some other additional measurements before we can consider them appropriate, which are here. We do all these measurements before taking these patients to the cath lab. So this patient had severe AS. This was his gradient. Mean gradient is around 45, max is around 80. Coronaries were calcified. We did fix them as well before we did anything else. So after we had fixed the valve, what we have to see is that what is the space left between the previously deployed surgical valve and their coronaries, and that plays a major role in determining what actual valve we can deploy in this position, because obviously our valve is going to cover the coronaries even more, and if there is already less than 4 millimeter distance between the coronaries and the previously present surgical valve, this can present a pretty high risk patient. So this patient underwent surgical valve aortic valve replacement of inside a surgical valve. We also can use embolic protection devices, as we have seen that although the risk of stroke is less as compared to surgical valve replacement, but we have now devices which cover both the carotids while we're deploying the valve, and it reduces, theoretically, it reduces the risk of stroke a bit more. Practically, we have not been able to prove it. However, MRI findings of patients who underwent TAVR with these with the Sentinel device showed that there was reduction in foci of calcium that were present in the brain after the valve, as compared to patients who underwent TAVR without these protective devices. So this is how a sentinel device looks like here. This is one filter, this is the other here. So after fixing the valve, this is us. So we would, because there was the distance between the left main and the valve was pretty narrow, so we would put in a safety stent in there before we put the valve in to make sure that it doesn't interfere. So following the, one second. Yeah, so this is after the valve deployment. If you can see this outer area, luminescent area is the previously present surgical valve, and this is our core valve, which is inside it, and this is the left main, which has a stent in place. So patient did pretty well after that procedure and was able to walk around and things, which for somebody who has already had 1 or 2 aortic valve replacement is unheard of in this day and age, because once they've done a couple of valve replacement, they are usually considered extreme risk and they would only be kept on medical therapy, which would mean a lot of heart failure admissions and a very miserable life. Potential complications include death, obviously, stroke or TIA, and then pacemaker risk, and then infrequent complications of coronary obstruction and annular rupture. Various new valves are coming through. Then coming to the mitral valve interventions, mitral regurg and heart failure, what we know from the US data is that moderate or severe MR is present in about 40% cases of advanced heart failure. And what we have seen is that MR might be a consequence of heart failure. However, once somebody develops severe, moderate or moderate to severe MR, then the severity of MR, the left ventricular function and symptoms, they are all correlated, and they all are proved to be a prognostic indicator for the physician treating them, these patients going forward. Etiology wise, obviously this is a normal valve. Then we have degenerated mitral regurg, which consists of mitral valve prolapse of at least one leaflet. The other one is a flail leaflet, where not only is it prolapsing, but also the cords are broken. And then the last one is the functional MR, where the actual mitral valve leaflets architecture is fine. However, the orifice has increased in size because either the mitral, the left ventricle has enlarged, or the left atrium has become bigger than its usual size. So the leaflets, even if they are normal, they cannot cover the entire orifice. Mitral valve interventions have proven to be a lot harder than aortic valve intervention. And one of the reasons is that mitral valve, the change in mitral geometry during systole and diastole is way more diverse than aortic geometry. And the mitral valve size changes about 40% between systole and diastole, which means that you cannot actually size, 30%, which means you cannot actually just size the valve to one particular size. If you size it in diastole, where it's 30% bigger, then once it's systole, there won't be any space for that mitral valve to actually squeeze in, and then that can actually cause harm to the left ventricle. So obviously all these issues considered, few options have come about. Either you decrease the size of the annulus with these cinching devices, you put in a clip in the middle, or you somehow bring the two sides of the annulus closer. So the most commonly and the first device that came around, and probably it is the most commonly used of all the possible devices that we have, is the mitral clip device, which is a surgical, it is based on Alfieri technique, which is edge-to-edge technique described in 1990s. And what they did was that in these high-risk patients who cannot stay or who cannot take anesthesia for too long, all they'll do is they'll go in the heart, put one stitch in the middle of the mitral annulus, make two orifices instead of one, and then over time, adhesions will grow around it and the mitral regurg comes down. So the first trial, so mitral clip itself, it consists of two arms and then these grippers. So the leaflets, what the technique involved is that we keep the two leaflets between, we have to catch the two leaflets between the arm and the gripper on both sides, and then close it, and then make sure we have enough amount of tissue in them. Obviously, it's on a beating heart, so it involves expertise and technique. So first trial was the Everest 1 trial, which was where mitral clip was compared to surgery for safety data. And obviously, a percutaneous technique, which involves only a venous access, was deemed way safer than a surgical valve replacement in a high-risk patient. Everest 2 was a properly randomized trial where mitral valve surgery or which involves repair or replacement was compared with catheter-based mitral valve repair, which is the mitral clip system. So it's a busy slide. What it shows is that in 5 years, 5 years after mitral clip, based on echo images, the patients who achieved +1 MR were less than patients who achieved +1 MR in case of surgery. However, NYHA class was very comparable. So even if you do not achieve the same degree of mitral regurgitation reduction with mitral clip, you still get a very comparable reduction in their symptoms at the end of 5 years. So this is what they have described. Then we went to functional MR, which is the COAP trial. And what they showed was mitral clip plus goal-directed medical therapy, guideline-directed medical therapy was way superior in terms of reduction in mortality and heart failure hospitalization versus guideline-directed medical therapy alone. All-cause mortality was again lower in the mitral clip arm versus the medical therapy arm. So this is how mitral clip is done. This is just a video which is going to show, this is mitral valve. This is the blood leaking backwards. This is us coming from the inferior vena cava from the right atrium into the left atrium. This is the device on top of a wire. Then the device, this is a steerable arm, so you can change the direction of it. This is the mitral clip device actually coming. So you have to position it on top of the actual leaking area. You have all the knobs and handles at in front of the operator to do it. The clip arms open up. You make sure you're in the right area and then you go down. You make sure the 2 leaflets are inside the clip and then you close it. So you have to obviously make sure you know what you're doing and you know you have done, or you have a very good imaging person with you to help you localize the exact leaflets or the exact scallops which are the one causing the issue. This is one of our cases. These images have somehow this is severe MR. You can see here. This is a 3D image of the same where you see prolapsing anterior leaflet. This is the baseline hemodynamics. So left atrial pressure, the normal left atrial pressure, the mean left atrial pressure should be less than 15. So this is almost 3 times the normal mean left atrial pressure. That shows how bad of a heart failure state this patient was in. So when we go in, we measure the distance to the clip to the actual area. This is the clip arm. These are the clip arms opening. You will see on the 3D there. These are clip arms have opened. Then you position them on top of the area which is actually leaking. So in this case, we ended up deploying 3 clips. I'll show you the end result. So these are the 3. This is how they look like on X-ray or on angiography. This is a small ASD which is left. This is the ASD we have to create to go from the right atrium into the left. And about a month after the clipping, there is no regurg. So regurg is completely gone. Acute complications are obviously procedural failure, cardiac tamponade, and LV dysfunction can worsen once you have put the clips in. Other devices which are around, most of them are in research phase or are being used sort of in infrequent places in all over Europe and US, are the sinus annuloplasty devices. And then we have all these direct annuloplasty rings, again, not being commonly used right now. And again, we have a metal-based device which actually supports the entire ventricle from outside and tries to reduce the area of the annulus by reducing the size of the left ventricle. So all these devices are being used. A few transcatheter mitral valves have come about, which are cardiac Q. We have the 12 valve. Cardiac Q valve looks like this. Then we have the tiara valve, which looks like actually a tiara. And then we have some of the other valves coming through, but none of them is being used actively and commercially right now. These are the 5 front runners in the market right now, which should hopefully be available in the next 2 to 3 years for commercial use. What we have for commercial use, again on compassionate use basis, is the SAPIEN valve, the balloon expandable aortic valve that we can put in patients who have severe mitral stenosis. And we can actually put the SAPIEN valve in them. This is another patient, a very old patient who had a surgical mitral valve replacement. Initially came into us with paravalvular leak. So you can see this is the valve and the leak of blood is coming from around it. So what we did was we put in 4 VSD occluder devices into these holes to plug the paravalvular leak, and the leak has reduced now. I will show you again. So you see this jet, this big yellow jet was there before the presence of these occluder devices. And once we put it, it's really small. Anyway, so this patient developed valvular leakage after that, and valvular gradients went up as well. So we decided to put in one more occluder device, which was causing from at the point where we could see a lot more paravalvular leak coming, which wasn't present before. Anyway, despite doing this, although his MR improved, paravalvular leak improved, however, his mitral valve stenosis did not. These leaflets are, this is the 3D image of the bioprosthetic surgical mitral valve. And these are the leaflets which are not really opening a lot. So there was a significant transvalvular mitral regurg as well as mitral stenosis because of the degenerated mitral valve leaflets. So because this patient was deemed inoperable, obviously has had 2 mitral valve replacement already. So we went and we decided for doing a SAPIEN valve in them. Obviously, we need our own measurements. So we have to measure how the neo-LVOT looks like. That's a term we use because this valve that we're going to deploy is going to come inside the left ventricle. And what it means is that the space between left mitral valve and aortic valve is going to get narrow. And that's where the LVOT or left ventricular outflow tract lies. So we have to do all these measurements to see how will the thing look like once we have put in the SAPIEN valve in it, and what we call it is the neo-LVOT. So this is how the actual LVOT looks like, and once the SAPIEN valve goes in, it will reduce the LVOT by about 1/3. This degree of LVOT reduction is still acceptable. Any more than that means you can't really do this particular valve in these patients. So I'll show you quickly. This is us going through the septum. This is us going. This is our device. With a wire going across the previously present surgical valve. And then this is our ballooning of the valve. This is a valve going up. This is us deploying the valve. In this case, we had to close the ASD as well because the patient had severe right heart failure. So we could not let the ASD remain there. So this is our ASD occlusion device. This is our surgical valve. Inside it is our mitral valve that we have just put in. And these are the 5 occluder devices. This patient had a lot of hardware in his heart leaving us. So what else do we have? We have interventions available for patients with tricuspid valve regurg. We can do clips the same clips that we have been doing on the mitral valve, we have been doing them in the tricuspid area. Obviously, they are much harder to do with the currently available devices because they're not made for tricuspid clip, but it is doable. We can, so the other things we have done is that we have again put in a sapien valve in the tricuspid position as well. In terms of what else do we have in for patients with atrial fibrillation, we know 15 to 20% of strokes in atrial fibrillation are related to 15 to 20% of strokes in a general population are related to atrial fibrillation, and we know that most of this is because of thrombus formation in left atrial appendage. So because of lack of time, I'm just going to quickly show you what are we dealing with. So these are the various shapes of left atrial appendage that we deal with. And obviously because they are of different shapes, so we have different sizes and different devices available to cater to them. This is how they look like on histology. So before we actually choose a patient for left atrial appendage occlusion, we would take various TE images and size the actual appendage in various various views to get an idea of what device would fit this appendage well. These are the various devices. I think the most commonly used in US is the Watchman device, but we also have the Plato device, and we have the Amplatzer devices, and some of the other devices are coming through as well. This is a Plato device. This is the Amplatzer device, LifeTech Pluto device. Then these are the surgical devices. The surgeons, when they go in to fix a mitral valve or something, they almost universally now occlude the left atrial appendage as well. Coming to the percutaneous devices in heart failure, again, we have the ICDs, we have very good data for intracardiac defibrillator, but we also have CRT, which, and we provide this facility at Shifa as well. Various studies have shown the benefit of CRT devices, both in terms of anatomic improvement, heart failure hospitalization improvement, and mortality benefit. Care HF showed again mortality benefit. What else? Oh yeah. So then we have these total heart failure pumps. Some of these pumps are being put in Pakistan, but again, success rate is a bit low right now. So we are not really doing these anywhere in Pakistan at the minute. And then some of the modalities which are in research, even in US, are these tissue engineering methods. We have all these biografts. We have these 3D bioprinting of heart models that can help us understand what actual pathology is going on. And we can actually now 3D print the valves according to a patient, particularly rather than using these 3 or 4 size devices that go into every patient. We can now actually 3D print a heart valve, which is very specific to that particular patient. Okay, thank you. I know we went through a lot very quickly, but I wanted to keep some time for question and answers. So I'll be happy to take any questions if you have. I have a question. 47-year-old male diagnosed with dilated cardiomyopathy and has a bicuspid aortic valve. EF is reduced 36%, is on medical therapy, working, and has a normal daily routine. So as we discussed, until the patient is asymptomatic, we don't have to do anything. However, this patient, although it says patient is doing well on medical therapy, has a reduced ejection fraction. So this patient should either be considered for surgical valve or transcatheter aortic valve. If he has already started reducing or affecting his LV muscle, that means this is the right time for doing some form of intervention. If surgery is deemed too high risk, which I don't think it will be, 36% is not that high risk for surgeons, especially in competent hands, and they can put in a metallic aortic valve in somebody who's 47-year-old, because remember, if obviously is deemed too high risk, then we can do a TAVR in them. But again, transcatheter aortic valves are tissue valves, so maximum life expectancy that we can expect is up to around 15 years. So in 15 years time, this guy is going to be 62 or 63. So that means again, we will be looking at some other form of intervention, versus if he is deemed at reasonable risk for surgical valve replacement at his age, he should go for a metallic valve. No, he's not asymptomatic. That's his ejection fraction is already reduced, so he's not asymptomatic. If somebody's pump function has reduced, this is the worst symptom that you can have. That's a good question. Are 3D valves effective? They are only in research phase right now. Some hospitals in Holland are doing it. We don't know the data yet. No.